And at that time, people used to always think that pediatric endocrinology is one branch, which is basically very, very rare, dealing with rare, complicated disorder, which require cumbersome evaluation and expensive treatment. This was a common thing. Everybody used to say, what will pediatric endocrinology do? Nothing much to be done this there. But when we started seeing patients, we were shocked by the way they were being managed. And this is one case with Dr. Rashmi and both of us managed. It was a very short child, diagnosed in 10 years with severe anemia, presented for the first time. And then at that point of time, there was a short stature and was given a blood transfusion, diagnosed as a case of celiac disease, but unfortunately had developed HIV because of the blood transfusion which happened in that scenario. So this was an unfortunate scenario, a case which should have been diagnosed at the right time and should have been managed in that perspective or missed in that scenario. So we thought, what are the problem? Is it a problem of awareness, accessibility, or affordability? Now everybody says it is always a problem of cost. So people say cost is a major problem. But what is the truth is actually the elephant of the house is awareness. If you don't know when should you go, where should you go, how you should be managed, it is difficult. Once you go, direction is there, people will help you. People will help the patient will help themselves, but most important is awareness. So from there, we started our program, and 2012, we had the first PPEC, and a lot of people here, including all the seniors, Dr. Subrato, Dr. Rishi, everybody was part of that program. And since then, we have conducted huge number of programs across the region in the country. But unfortunately, how many physical programs one can do, that is a limit to that. So we started the advanced programs as well. So we moved forward from there to internet media, because now internet is available. So we started on YouTube around 7 years ago. And from there, we moved forward towards a structured program, both on-site as well as online. And now we have got the application and other things which are happening. We have e-learning program, which has got huge number of subscribers, and all of you would have accessed that. This would be something to go forward. But problem with YouTube is that you can see one video and then you forget about it. So if you want to have a systematic learning, we started off with this program of MedEClasses 4 years ago, in which we now have a fellowship program and a diploma program. A lot of programs are there. A lot of people are part of that program as well. Now, we also run regular postgraduate fellow classes, and the publications and applications are there. Applications are going to make very easy day-to-day management in that regards. The often problem which still remains is that the number of pediatric endocrinologists in the country may be around 100, and 100 may be an overrating, exaggeration. Cases are thousands. So what do we need to do? There needs to be a bridge between cases, pediatricians with special interest, and then more pediatric endocrinologists. This is what we are looking at. For that, now we are trying to come up with a solution, which hopefully will come up in the next 2 to 3 months, which will help you out using a personalized, intelligent EMR. So what it will do is that based upon your particular problem, so if a child has short stature, once you say short stature, specific questions will come with regards to history, examination. This will be there for all conditions. So precocious puberty, delayed puberty, DSD, whatever, 40 conditions we are developing these protocols. You just have to enter these data. Once you enter, you will ask specific questions in examination. So for a delayed puberty, it will ask anosmia. For precocious puberty, it will ask about headache. So different questions will come. Once you answer those questions, put basic data while you are examining the patient. This is looking very benign, simple. You're just putting, but what is, and you can simultaneously assess bone age there. So it looks very simple, you're doing that. But what is happening is that behind the scene, algorithms are running, which are then telling you this is the diagnosis, this is the investigations required, this is the likely treatment, and then you will get a lot of output. And you can then export it in the form of a proper, it will give you like a proper history has been taken, you will get results, interpretation. This is a work in progress. Lot of intelligent algorithms required. It will take time, but this is the way forward. So this will allow everywhere across the country to have a state-of-the-art, quality assured sort of a management, and then there could be connections with clinics as well. So this is something which we are working in that direction. Last 3 days, we had very intense program in the Regency Center for Diabetes, Endocrinology and Research. Over 30 people from across the country had come, and it was a very good interaction with over 300 cases in which a lot of interactive discussion. So genetics, just to understand, we have all been taught that there is a central dogma that you have a gene which produces a protein which is then translated and causes a phenotype. So there is a genotype to phenotype correlation. But now life is not very simple. There are many other factors which affects this genome to phenome combination, and these include epigenetics, which means environmental effect on genetics, where methylation and other things come up, genetic modifiers, miRNA modification. So a lot of factors are there. So when you are assessing a genetic report, you have to look at a total number of things before you really say what is right and what is wrong in that regard. Now, just to talk about inheritance, typically we know Mendelian inheritance is monogenic. Oligogenic is an interesting term in which many genes together cause development, and the classic example for that is which disorder in endocrinology? Hypogonadotrophic hypogonadism has an oligogenic inheritance, and most other like type 2 diabetes, type 1 diabetes have a polygenic inheritance. I will be focusing mainly on monogenic, which is of course the most common and significant in that perspective. Now, monogenic can be Mendelian, which means they are following the rules of Mendel, which may be dominant, recessive, X-linked, or non-Mendelian, in that there are some variations there in the form of whether it is penetrating, whether it is expressing, whether there is methylation, and a lot of other issues which come out there. Mosaicism, imprinting, we'll discuss all those cases in that scenario. So autosomal dominant, just to summarize, it basically means that one gene is enough to cause manifestation. Parents will also be affected, child will be also affected, 50% chances there. The generations will not be skipped. This is classical Mendelian inheritance in that scenario. There's no carrier, and if you have full penetration, everybody will be affected. Recessive basically means you are skipping generation. One generation may not have, and when you have a consanguineous family, both genes come, 25% chance of recurrence. This is basic genetics. I'm just going through very quickly to just recapitulate. And X-linked inheritance, of course, means that it is not inherited from the father to the child. Father gives to the daughter, which is basically a carrier. Mother is a carrier, but gives to the child. This is a basic thing. History will be there in maternal uncles, in maternal cousins, and all that history. We saw a lot of X-linked disorders like adrenal hypoplasia congenita. We suspected that in that onset course. So these are all X-linked conditions. ALD is again an X-linked condition in that regard. So this is something which is there. Now we'll start off with cases. And the first case, Manoj, is?
So we have a 3-year-old boy who was diagnosed as a achondroplasia, but family was unaffected. As we know, achondroplasia is autosomal dominant disorder, but family was unaffected, and we just gave reassurance.
So we did not send to Dr. Poonam and we said, okay, nothing is going to happen to the next child. Be happy. It's an autosomal dominant condition. So now what happened?
But what happened? Next child having achondroplasia. So what was the mechanism behind this? Why it is occurring?
So Dr. Poonam, what do you think would be the?
The most common cause in sporadic type of these conditions is gonadal mosaicism, that one of the parents is having a particular group of cells in gonads that is mutated. So it depends upon which time, whether the mutated sperm or the egg has participated in formation of the embryo. We have no methodology by which we can prove this. Like this, clinically, when the next child is born with the same condition that is known to be a sporadic one, and the parents are actively normal, then it is considered as a germ. And for few conditions, it is known that there is certain percentage, like this achondroplasia, we have like less than 1%. For Duchenne muscular dystrophy, if mother is not a carrier by blood testing, and she has a second child with DFB, then this percentage is known as high as 15% for Duchenne muscular dystrophy. So this is a known thing.
So this is a gonadal mosaicism. So don't always say that if it autosomal they are dominant, parents unaffected, it's not going to affect them.
So we have 2-year-old girl child who developed vaginal bleeding. Breast size was 2 and pubic hair was 1. and patient have capillary spots and ovarian cyst was there. So our working diagnosis was McCune-Albright syndrome. So according LH was suppressed and FSH was also suppressed, but we did GNS1 test which was negative. So why it is occurring?
So I think this again is the same mechanism. This was germline mosaicism. Here we are talking about somatic mosaicism. So we all know post-zygotic. If you have a defect, you will not find on the blood in every cell. This is very common. We know this about Turner syndrome. That's why you see so many mosaicism have to be looked into. Similarly, McCune-Albright is a somatic mutation. So I think this is something which is again very, very common and we need to be aware. So how do we make a diagnosis in this case, Dr. Poonam?
The most probable affected tissue to take,
Yes.
if we are able to take the sample from the cafe or a sports house, skin biopsy will be the most accessible.
Or if there's an ovarian cyst and somebody has taken the fluid out of it, you can get it done. So this again, it means that if you don't find it blood, it doesn't mean that it is not there. It is there in some tissue. This is what mosaicism is all about. So somatic mosaicism, we all know McCune-Albright, different tissues are affected. You will have thyrotoxicosis, precocious puberty, you will have polycystic fibrous dysplasia and all those problems depending upon which tissue is affected. Remember, if you have one tissue, only one manifestation may happen. So earlier we said triad of fibrous dysplasia, precocious puberty and cafe-au-lait spot. No, you can only have ovarian cyst in McCune-Albright syndrome. You can only have thyrotoxicosis. So depending upon which cells are affected, you will get the diagnosis.
So we have 5-year-old girl who having hypocalcemia. Calcium was 5.6, phosphorus was high. It is suggestive of impaired PTH effect. PTH was 5.2, which was suggestive of hypoparathyroidism and patient having growth failure. We did NGS, which was suggestive of rate 1 mutation, and there is no family history. So what we have to do in this case?
So this is a very interesting scenario. You have done an MRI for headache and you find a pituitary adenoma. We call it incidental. You did test for hypoparathyroidism and you found a RET1, and RET1 we know is medullary carcinoma thyroid. So this is a genetic incidentaloma. Now, Dr. Poonam, do you think this child has the same chance of malignancy as somebody who already has a family history of thyroid carcinoma? Because the big question now comes whether we go for thyroidectomy or not. So one is that you've done for the family and then you did it is positive and this is incidental. So are they the same or do you think there could be some difference?
The age of manifestations actually the highest is within 1 year.
Yes. Yeah.
So probably that part has been
escaped from that perspective.
But still we can keep them at surveillance. It's not
Yes.
indicated maybe.
Yes. So what we need to understand is that this basically is an important issue of penetrance also is important. Now, if you do a whole genome sequencing in any of us, 20 to 30 defects will be there in us, but we don't have any manifestations. What it means is that other factors are saving us from having a disease. Suppose your androgen levels are low and your androgen receptor is working well, so you are compensating. So like that FAH which we are talking about is basically hypersensitive to ACTH. That is a base, it's not a disease, but they are responding well. So what basically means is that you need to understand what is penetrance and what is expressivity. Penetrance means that out of how many people, how many have actually the disease. Expressivity means out of them how much they are expressing. So it may happen that you have variable penetrance, you have variable expressivity. Somebody may have a milder disease, somebody may have a severe disease. Now, if the family already has shown that there is thyroid cancer, I will be very, very bothered about it. In this case, as Dr. Poonam said, if already 1 year is gone, chances are less, but the family doesn't have. So he either has a sporadic mutation or if it is familial, it is not that severe. Other factors in the family are saving it. So remember that beyond a simple Mendelian inheritance, penetrance and expressivity play an important role in that scenario. So you can have variable penetrance, variable expressivity.
So we have 10-year-old boy with obesity. Patient was normal till 3 years of age and now having rapid progressive obesity. Patient having hyperphagia also.
So diagnosis, we saw these cases. So you're thinking of Prader-Willi syndrome as a possible.
But we and patient having small pelvic size, but fish was normal. So why this fish is normal?
So very, very high level of chance of Prader-Willi, but we got fish, it was normal. So Dr. Poonam, what do you think was it the right test to do fish?
See, you pick upon availability because most common is deletional form. 70% is deletional form. So we can say it logically it may be opted for the first time, but yes, mutilation is the most sensitive one because it will pick up 99%.
So this is an imprinting disorder, and 70% cases that paternal gene is gone. The other cases, there may be some epimutation, there may be some methylation changes which will not be detected on fish. So if you want to go for MLPA methylation, 99% cases, you will pick up. This is very common. So fish is earlier good, but now MLPA comes for around 8,000 rupees also. So I think that's a reasonable test to do. So MLPA is a new technique which will give you, not a new, but it's a good technique to diagnose the condition. So remember, there would be issues in diagnosis. Don't just say fish negative, it cannot be Prader-Willi. There can be other situations as well. So imprinting is a group of disorder in which the genetic manifestations depend upon whether the gene is coming from the father or the mother. Typical case in endocrinology is Silva-Russell syndrome, Prader-Willi syndrome, Beckwith-Wiedemann syndrome, SDH paraganglioma, transient hyperinsulinism. A lot of these disorders are there which are there. And so they are becoming, and pseudo-hypoparathyroidism, I can't forget, that's a very important one in that regard. So you have to be aware that imprinting comes. So suppose you have PHP, we discussed yesterday with Dr. Nitya, that look at the mother, don't look at father because it is never going to come from the father. So look for mother, whether she is short, round faces, whether she has brachymetacarpia or not, then it will come because it is an imprinting disorder. Father's defect will cause only skeletal manifestations. It will not cause hypocalcemia. Mother's defect will cause both manifestations in that setting.
So we have a 21-day-old boy who having irritability and patient having mild dehydration. Calcium was high, 14 milligram per deciliter. PTH was also high, 120 picogram per ml. Urine calcium create ratio showing lower side, 0.1 milligram per milligram. And the father we have found familiar benign hypocalcemia, and the mother was normal. So why this child having such a severe presentation in newborn periods?
So I think this is again an important consideration. We know if both genes are affected, that is autosomal recessive severe form of hyperparathyroidism. But here only one gene is affected. But yet the child has hyperparathyroidism. Anybody can have a clue why is it happening? No, this is basically a calcium sensing mutation is there, but only one gene. Because mother has normal calcium. So this baby, for him, the mother's normal calcium are actually low. So that is why he is having this hypercalcemia, and this will improve over time. So this is not really imprinting. This is pseudo imprinting in which the body is behaving such that this is a case. So if both genes are affected, you will of course have a severe form. There is no confusion. But if there is an effect which comes from the father, mother's levels of calcium are falsely found to be low. So if you talk about GDM, what happens? Your mother's glucose is high, you become hypoglycemic. Similarly, he perceives that mother's calcium is actually low, so he becomes hypercalcemic. This will resolve over time. So this is a very interesting scenario. If it comes from the mother, it will be a benign condition. So again, it is looking like imprinting, but it is not imprinting. You got the point? So basically, mother is being thought to be hypocalcemic by the child because he wants calcium to be 12. He is not happy with 9. That is why he develops hypercalcemia.
So we have 7-year-old boy who having growth failure. Height was short. Weight was 16 kg. Patient having doll-like faces and peak growth hormone was 2.1. Liver was 10 centimeter enlarged, thumb, and SGPT was very high.
So this is GSD. Which GSD? Type 1. So this is a late presentation. Lactate is normal. I haven't given the figure. Liver is very big. SGPT is high. So this is GSD 3. Most likely GSD 3. Now what happened, Manoj?
So as sir discussed, our working diagnosis was GSD 3. But we did a blood investigation in that the reports came negative. So why it is occurring?
So we got the GSD3 study, which was negative. Then what do you think would have happened? This is a very common genetic thing. What is known as locus heterogeneity or phenocopy. Now, it's not just GSD3, GSD6, GSD9, all of them have similar features. So then comes the importance of targeted panels. So if you are 100% sure this is the disorder, you go for that particular Sanger sequencing. But if you are unsure, and if you have a number of disorders, suppose you have XY DSD, nobody on the earth, as Vibha was saying, XY gonadogenesis, you don't know it is NR5A1, this is WT1, this is SRY. So if you say SRY, then every time you keep on doing tests, it will be huge money. There comes the role of targeted panels. So Dr. Poonam, what do you recommend in terms of like, where should we go for a specific test and where should we go for a targeted panel?
It depends upon if you are very, very sure, like achondroplasia. It's a evident diagnosis. Even we don't sometimes go for then that is one gene, one test. Kind of. But it's this like GSD group. So we have several types and several genes. But you are pretty sure that it will fall under that group. So then it is good for going targeted. The difference for the lab comes for once you go for a targeted panel, they look into exons, they look into peri-exon, splice site. So the depth of this splice site is also bad depending on the target is. Like I've seen 12 genes in a group, so they will see the splice site up to the depth of 100 base pairs or something. But once you are not very sure or clear of the diagnosis, like mental retardation, could be a non-syndromic type. Like most common nowadays is autism. Right, so autism has 40% kinds of genetic background, but sometimes the child has nothing as a physical feature. So then in those cases you go for a wide field. And you cannot say for a targeted, so then you have to go for many genes, maybe clinical exome, maybe whole exome. So then once the lab takes number of genes or more, the depth reduces. So they will be seeing all the genes, all the exons, but maybe splice sites the space pairs, these space pairs. So depending upon your clinical diagnosis, you should order the test and accordingly the lab will reply. And obviously the diagnostic yield also varies. The highest yield is with targeted panels and it reduces it's more wide.
So basically, let's say this way that suppose you want to learn about a particular topic and you know I want to read only about XYDSD. You're going to read only that part. Then you say I want to read about entire part about gonads. Then you have to read the whole book. So if you read the whole book, you may miss 1 or 2 points. If you're reading only one paragraph, you will be more focused. So if you do single gene Sanger, that is of course gold standard. It will say yes or no. If you do a targeted panel, you will be able to read, okay, it is correct. But if you read the whole book, you may miss something. But if you don't know where to find, you have to read the whole book. That is what Dr. Poonam is saying. So single gene defect, you go a Sanger sequencing, otherwise targeted panel, clinical exome, whole exome. So this is the way you decide.
So we have next case, a 12-year-old boy who having obesity, weight was 67 kg, height was 156 centimeter, plus 1.2 SDS with normal faces and normal development. So it is looking like a physiological obesity. So either in this case, should we have to advise genetic test or not?
Now everybody is doing genetic tests. We have seen patients in which no biochemical tests are done and genetic test is done. So which condition should we do a genetic test, Dr. Poonam? So what are the indications? Suppose like obesity is very common. Which obese child shall we do a genetic test?
Subcellular syndrome.
Yes.
That is clear cut.
Sure.
But like in this case, I would like to see for the parental height.
Yes. So we will look for thyroid, all other things before you.
Parental height, thyroid.
So what about this girl? 2-year-old girl, weight is 24, rapidly progressive, hyperphagia is there. So this case, I think everybody will agree a genetic test needs to be done. Yeah. So what Dr. Poonam has said is what we discussed, 4S, soon, severe, segregating in the family and syndrome. These 4 cases you have to do the genetic testing basically. In all these 4 cases it becomes important. So this is what first case, it is waste of money. Second case, you have to do it. So too soon becomes important. So this child had early, severe, unusual hyperphagia was there. and we found a leptin receptor and other receptor defects can come. So now to summarize, genetic techniques can be sequencing in which you are reading each and every sequence. Now sequencing could be the Sanger one or a next generation one. You compare this versus that, or you go for a particular locus, fish and karyotype cytogenic techniques. So these are the various techniques. So just to summarize, in Sanger, you are going one by one. You're looking at, suppose you are in charge of the railway, you're looking at each track and seeing how it is going. So this will be the Sanger technique. The other one, you look only at patches. This is like the fish technique. And the other one would be that you have 100 people employed and they are looking. They are not as good as you, but they are at least looking there. So if I summarize this, the one in which you are looking at everything is Sanger technique. Second, NGS, you've got thousands of probes looking at different regions. You are at least looking them. You may be having an error or not. That's a different question. If you're looking at specific regions, that is fish. So depending upon what you want to look at, you will then make a diagnosis from that regard. So Sanger, I won't go into technique, is a way of looking at each and every DNA sequence from there. NGS has a much more high throughput. The technology is becoming better. So over time, we expect it to be much better in that scenario. And this is going to be there. And so now the next big issue comes is when you find a variant. Now we don't call anything as mutation. Earlier people used to say mutation. Now we call variants. And now the question is, when will you say a variant is pathogenic? So if it is in the family, if the gene frequency is low, if it has been there for millions of years and suddenly it has changed, if you have clinical correlation, if you have a functional study, and then there are prediction models. So in silico study means you not have clinical tests, you just predict based upon computer, what computer is saying, and you get the result. So every variant you identify is not pathogenic. It may be variant of uncertain significance, it may be benign. So like radiologists say category 1, category 2, pathologists say category 1 to 5, same. Genetics now talks about benign, variant of unknown significance, and a pathogenic, definite pathogenic variant in that regard. This is the point Dr. Poonam was saying. Single gene, one mutation, hotspot testing you can do. Single gene, multiple mutation, do a Sanger sequencing. Multiple genes, go for a targeted next generation panel. Unknown, whole exome, whole genome, then you keep on looking at. You are trying to find the needle in the haystack. And copy number variation. Now, what is copy number variation, Manoj?
It is a gene defect that occur due to the deletion or duplication.
So small areas, it's not a single nucleotide. Some come, some go. There you use MLPA or FISH in that technique. And multiple genes, you want to compare multiple, you go for RACGH and MLPA in that regards. So likely monogenic, unlikely, no, don't do unnecessary testing. If there is there, you have candidate genes 1 to 2, do sequencing. Up to 20, you can go for targeted panels. Normal or unclear, you go for exome sequencing. And if it's abnormal, go for functional study. And if everything is normal, you can go for genome sequencing. So not everybody requires genetic testing, but go by sequence. Now we will go through a few cases.
So we have three-day-old child who having DSD and palpable gonad was there. The other stage was 4, but there was no gonad. Uterus present and the karyotype is showing 46XX. 17 hydroxylase was in borderline 25 nanogram per ml and diagnosed as a CH. A hydrocode tapered according to 17 hydroxylase and 17 OHP was normal, but patient having delayed puberty but there was a typical history of maternal virilization was there and genetic report was showing.
So what do you think here? Clinical diagnosis first. So this looks like a aromatase deficiency. Now this is the clinical report, Dr. Poonam. They are saying it is autosomal recessive inheritance, aromatase deficiency, both alleles are affected. So do you think this is significant? So this is likely pathogenic. And in fact, we are diagnosing aromatase deficiency. The report is there. I think there is pretest probability is so high. So when you look at the classification, which is very, very important. And they also tell you how common it is, how much it is conserved, all the points I said is there. But this is the key thing to look at. Whether it is, and it is fitting your diagnosis or not is very important.
So we have 6-year-old boy who was failure to thrive. Birth weight was 2.4 kg and now weight was 2.5 kg. Bilateral gonad was there, and in USG there was no uterus. Testosterone was high, 17, OHP was borderline 30. Sodium was 126, potassium is 5.8, showing impaired RAS effect. So now genetic report showing.
So now we have got this child with hyponatremia, hyperkalemia, borderline 17 OHP. Now we are getting this result as 3 beta HSD deficiency. Again, pathogen. So I think Dr. Poonam, we will think that this fits into the diagnosis. So we will carry on with the same diagnosis. So this is clearly a targeted panel which is showing the defect.
So we have 6-year-old girl who having diabetes and which was diagnosed in infancy. Patient was insulin and patient having disease abnormality, which was showing it could be the Mori type or syndromic associated. And inpatient GAD was negative. So type 1 is out and we did genetic investigation.
So digit abnormalities and diabetes, what are we thinking of? Digit abnormalities and diabetes, anybody? Not obese. So this is what came out. EIF2AK3, which is basically for Volcotralis. Now they are saying uncertain significance. Now Dr. Poonam, does it mean that it is not Volcotralis? Clinically, I am thinking of Volcotralis. There is digital abnormality, diabetes. I thought it could be Volcotralis, and they are saying uncertain. So do you think it is? What do you think most likely it will be?
If it is going with the clinical diagnosis, then it will be likely pathogenic. But because the type of variants are such, that is making the lab to lower side.
So lab is not seeing the patient. You are seeing the patient. And lab is basing upon their probability prediction models. So you have to look, okay, for me it is positive. This is classical case. I was expecting this, it came out. So again, use your own, as I said, most important part will be between your eyes and the back of head, which will give you the diagnosis in that scenario.
So we have 8-year-old boy who having short stature, height was 92, -2, 6.2 SDS, small child was SGA, and there was a normal metabolic workup, NGS advice, and but in NGS we found there was a 10 variant of unknown significance. So in this particular case, what we have to do?
So none of these variants were explaining his short stature. So what do you think, Dr. Poonam, would be the way forward? And none of the clinical features were there for those variants.
On what type of NGS was done? Was it a targeted panel? Was it a?
It was a whole. It was whole genome.
Whole genome has a very low sensitivity. Yes. Percentage 30x less to that. So when we go into will have a better test. Number two, it's not always that like you said, every variant does not cause the disease. So we have to look into it's called reverse phenotyping. The patient once again, try to correlate, try to find out more clinical markers, and then you can send the clinical features to the lab and ask them to be on the basis of these new clinical findings and please read the data.
So what I'm trying to say is that when you do whole exome and these sort of sequences, you will see a lot of reports which are of no sense. So don't do wide reports. There are specific guidelines of reporting also. So now labs will not even report those ones. They will say only if they are very, very significant. So this is something you may get unusual report. Don't get worried about that if it is not fit.
So we have 29-year-old lady who was diagnosed as a man 2B, which was severe variety. The sister's son was 3 months old and concerned about MCT, medullary carcinoma of thyroid. So, and the genetic was suggestive of genetic study rate 918 defect was there. So in this case, either we have to go for thyroidectomy or not.
Yeah, so I think this is what we were discussing, that there was no family history there. The family history is there. You have to be clearly worried that you should do something. So I think this is where genetic prediction comes very, very nicely out here. So this required immediate surgery, and this is prediction can be there.
So we last case we have 12-year-old girl who having incidental hyperglycemia. HbA1c was well controlled 6.5. Fasting sugar 128 and 2 hour sugar was 135. Ketone was negative. BMI was 16. So might be we are dealing with the MODY type. And GAD was negative. So type 1 is out. And now child was on the genetic test, it was GCK deficiency. And what will advise now?
So this again is the case we saw recently in the on-site course. So this case, this genetic diagnosis helps us a lot. It tells us that this is a non-progressive diabetes. We don't need to bother, don't require insulin, won't require anything else. So we have shown how genetic tests can help you reach a diagnosis, prognosticate, tell you what will happen in future and go forward in that perspective. So I think this was the learning point will be genetics is now integral part of modern medicine, but select the right test, appropriate technique and interpret it properly, and always be close within our arm's reach of your geneticist who will be able to tell you how it will go and how to interpret from that regard. So I think this was a good discussion. If you have one or two questions, we'll take and then we'll start with our inaugural session.
I'd like to know what is the difference between clinical exome sequencing and whole exome sequencing, number one. Number two, when we get, we have high predictive probability and all the features of certain diseases there, and you order genetic test, and it comes out to be non-pathogenic. So it uncertain significance. So is it the novel variant we are getting, or it is not in their database which is causing pathogen?
So I'll answer the second question and Dr. Poonam will answer the first question. So second question answer is that maybe they don't have enough data to say that that is pathogenic. In some time, they might get more data and you suppose you report your case, it may become that this is pathogenic. So this will change. It may change over time. Now, Dr. Poonam, very important, whole exome versus clinical exome versus clinical whole exome.
The clinical exome, out of the 23,000 genes that we humans have, 18,000 genes for clinical relevance is known till date. And this whole exome sequencing actually reports the 18,000 genes. Out of that, if we say the most clean part of 8,000 genes have been taken up into the clinical exome, that will be able to detect 60% of the patients with genetic disorders. So what it was thought like maybe 2 years back, the stepwise approach was there. At clinical exome, 8,000 genes was the first test to be ordered in any suspected genetic etiology. But you should be sure that whatever is your clinical diagnosis and the most common gene associated with it is covered in that clinical exome. If it is there, then you should order the clinical exome because there is a difference in the cost. There used to be a difference in the cost, but now it is like the cost difference between clinical exome and whole exome is very narrow, maybe 2,000-3,000. And the other thing is the depth of the reading of the machine in clinical exome and the whole exome is same, almost same. So now gradually the clinical exome is becoming outdated. And so once you think of a monogenic disorder, you actually go for a whole exome, that will be a wiser choice. But always and always give a good clinical clues or handles to the lab. Then only the detection will be. Otherwise, it's something like सब कुछ देख लिया, सब कैसा डाल दिया, 50% is normal. So you cannot rule out until if you get a normal report does not mean that a patient is not a case of genetic disorder. That is very important.
So it is something like you were saying that if you have some short stature, you start looking at molybdenum, selenium, all those levels are coming and then you say this is high, this is low. So you need to look at specific things. That is the first thing. If there is confusion, then you go. Otherwise, it's like in the dark, you are just trying to find things and that may be difficult. I think last question, Dr. Seema.
What is gain of genetic? Gain of function difference.
Gain of function.
Gain of function. So any defect in the sequence of a gene that is increasing the protein content and then causing the defect on the higher side. Like achondroplasia is a gain of function defect.
Like activating mutation, like McCune Albert DNA, activating mutation.